Hello, hello, hello. Good evening, everybody. I hope you can get my audio. Just confirm with a reaction, an emoji reaction, if you can get my audio. Right, thank you. Thank you so much. I see that my audio is clear. Welcome to the session. We are about to start in a few. We encourage you to remind your colleagues, your friends at work who have not yet joined the session to join so that we begin together and don't leave anyone behind. So kindly take this opportunity to just send a last reminder to your friends and colleagues. In the meantime, I want to assess who is in the room with us. And for me to get to know this, I will encourage you or just ask you to share in the chat box which county you are listening in from. And that will give us a good picture of coverage. Yes, thank you. Thank you so much. I like that you are firstly responding. I see Garissa, West Pokot, Nairobi, of course. Karibu sana, karibuni sana, Janet, Nakuru, karibu. Thank you so much. Continue. Yes, I can see more Kisumu County, Taita Taveta. Yes, this is very pleasant to see. Okay. By way of introduction, my name is Dr. Silvanus Manyala, and I am pleased to be your moderator for this evening session. And as you can see on the screen, the webinar topic is one that is of interest to us as pharmacists. We'd like to be updated on the current approach of the management of erectile dysfunction. And I'm so happy that we are joined by a distinguished speaker who I will introduce a bit later as well. But just to note that we are ready, the speaker is ready, and we are hoping to have a very successful engagement. Right, so this is how the session looks like. This is how we will deliver this webinar. I'm going to share a few ground rules, and then we'll invite the speaker to come in with a very powerful presentation. And then afterwards, I'll give an opportunity to our sponsor of the evening to also just share a bit of their profile and what message they have for us tonight. And then an opportunity for you to engage both the speaker and the sponsor in a Q&A session. Hopefully this will be very interactive. Would like to hear from you and get responses as well. And then we will close afterwards with some brief announcements as well as remarks. So as I've highlighted, we would like you to know that you will remain muted during the entire course of this session. If you'd like to interact with us, if you'd like to share general remarks, we encourage you to use the chat section. And if you'd like to raise questions to the speaker, to the sponsor, or even to myself as the moderator, at the bottom of your screen, on the many icons, you should see a Q&A tab. If you don't see it as one of the primary icons, there's a 3-dot icon labeled more, where you can just pose your question over there, and we should be able to address them progressively or during the Q&A session. Please note that this session is being recorded, and we'll have the recording available on our YouTube channel. Of course, the event is CPD accredited with a 7-day window for subscription and claiming of tokens. And we have the webinar already existing on the PPB portal. So even right now, if you can, just rush to the portal, search the event. You can use the keyword erectile dysfunction, and it should come up and subscribe. And that's how it will look like on the portal. So just for ease of navigation, they provided the Pharmaceutical Society of Kenya, and you should be able to easily access this. All right. Yes, thank you. Now allow me to switch real quick the next 1 minute and introduce our speaker, Dr. James Dungo Ikol, who holds an MBCHB and MD in surgery from the University of Nairobi, and a fair fellowship in urology from KCMC, and also SAT MAS from IMAST Mumbai. He is a urologist and currently working at the Kenyatta National Hospital, where he also serves as the head of the urology unit, a former lecturer and department chair at Kenyatta University School of Medicine. He's a member of the Kenya Association of Urological Surgeons, where he currently serves as the vice chairman, and he's also a member of the Society International. Yes, this is the European Association of Urology and the American Urological Association. Yes, it's quite of some tank work there. But welcome so much, Dr. Ikol. I wish to give you the floor to just build on that introduction. If there's something that you feel like it's important to mention about yourself, again, this is the platform to do so, and then pick it up from there. Karibu sana, Daktari. The floor is yours.
Okay, thank you very much for that kind introduction. I just want to warn you, somehow with Murphy's Law, what can go wrong goes wrong. I heard the previous speaker mention that if you can hear me and can see me, I think put a sign. I think it's a very good way. So in our association, usually we keep asking, can you hear me? Am I audible to everybody?
Yes, Doc, you are audible.
Okay, thank you very much. Just a warning that while preparing to log in here for one reason or another, the Wi-Fi in my office went off, and so I ended up on something Simon taught me. So Simon, if I go off, you load the bundles so that I don't lose track of what is going on. So, erectile dysfunction, we want to see how we can bridge clinical standards and our practice in East Africa. And for all those who are here, the management of ED really matters. As a matter of disclosure, I was asked to give this presentation by CC Pharmaceuticals, who are peddlers of this medicament, and maybe they might consider buying me a cup of tea after this. So it is not uncommon that you have met your friends in your outings who say, Daktari, it has refused. They never tell you what has refused, but it tells you, Daktari, it has refused. This is a very common phrase where we sit. And right now we are having two interesting scenarios. Once upon a time, our typical patient would be a person who is 70 years old, probably obese, with comorbids. They may be walking on crutches, could have had knee surgery, hip surgery. They may be on treatment for cardiovascular disease, hypertension. Their blood pressures may be well controlled, but again, they may have kidney dysfunction. Typically, this patient was diabetic and hypertensive. So that is the profile of the patient we were used to seeing, and indeed that's the profile of the patient for which we were initially focusing on. Right now, the demographic has changed. And here we have Mr. Mundu Strong, who is typically a 28-year-old, physically fit individual, exercises 3 times a week, 72 kg, which is normal body weight as we were taught in physiology. And as part of his routine exercise program, he runs 15 kilometers every second Saturday of the month and has been dating for 4 months. And this particular person, when you ask him his frequency of intercourse, I mean, it's a clinical scenario, a person who has come to you and he says he has ED. And when you ask the person of the frequency of intercourse, he tells you, I do it twice a day, or I aim to do it twice a day. So now we are dealing with a completely different demographic of individuals now seeking care for erectile dysfunction. What am I interested in doing today? My objectives in this discussion is that at the end of the day, we should be able to understand the epidemiology of ED in East Africa and indeed globally, have a slight explanation of its pathophysiology, and more important, to recognize ED as a symptom and not a standalone disease. And because of that, it will serve as a cardiovascular and metabolic marker, and then go through the review, the treatments that are available, and at the end of the day, see how successful treatment of erectile dysfunction influences overall health. What is ED? It is persistent inability to achieve or maintain an erection sufficient for satisfactory sexual function. This is an international definition. However, for our purposes, we would like to add, or we would like to say, sufficient for satisfactory vaginal intercourse. So ED matters because it is more than a quality of life issue. It will impact a man's self-esteem, causes depression and anxiety, will lead to relationship difficulties, and is associated with cardiovascular disease. And indeed, it can be a manifestation of endothelial dysfunction. Traditionally, we classify the causes of ED into organic and psychogenic causes. And then, of course, there is a mixed form, and typically, most of the time, they will come up as a mixed form. Among the organic causes we know are the vasculogenic causes, where and this is typical in diabetics and hypertensives, where they generally would have atherosclerosis. The other is a neurogenic dysfunction, where we have persons, for example, with nerve spinal cord injuries or neuropathies of one form or another. And common endocrine abnormalities, one of them being hypogonadism. Aside from that, we also have diabetes under this particular class. And then the anatomical disruptions. And common anatomical disruption that we see is a penile fracture. We also see people with hypospadias, people who have had traumatic amputations of the genitalia. These are some of the organic causes. And of course, in people who have testicular descent problems, those will have their ED mainly caused by the hypogonadism. Performance anxiety is a leading cause among the psychogenic causes, and right now we are living in an extremely fast-paced world. So there is a lot of failure to meet targets, and depression sets in, and that is a major contributor. And then, of course, both with their failure to meet your targets and leads to interpersonal conflicts within the family, also contribute to psychogenic causes. There are avoidable reasons, there are avoidable causes for erectile dysfunction, which we have in our society now, where there's a lot of use of cat, there's a lot of use of tobacco and shisha. We have a very high level of alcohol consumption in our country. And then we must never forget some of the prescription drugs that we give as a part of the causes of ED. A common one now being the gabapentins is a real major cause of erectile dysfunction. Globally, the burden of erectile dysfunction is such that by the close of last year, it was estimated that there were 322 million men estimated to have ED. And it's good to note that the prevalence increases with age. And if you take the age group of above 40, where I am, at least 52% of us are likely to have erectile dysfunction. But it's good to note that there is significant underreporting of erectile dysfunction globally. In our Kenyan setup, a community study has been done by one of our urology colleagues and a team in Kemri, where they looked at an age group of 18 to 35 years of age. And in that age group, they found ED prevalence of around 10.4% in this community, of varying ranges. The good part is that in this young person severe ED was there in only 1.4%, and most of them had mild or moderate ED. Suffice it to note that a lot of the ED that was seen here was related to depression and anxiety, basically telling us sometimes the pressures of work are not good for us. In a study done by Professor Elijah Ogola and his team, Joshua Kaima, and they looked at erectile dysfunction in hypertensives, and the prevalence was 94.5%. Most of them having mild, but severe also being there in 10%. Further looking at our East African brothers, where they looked at diabetics, interestingly, in this cohort of diabetics, they looked at the prevalence was only 55%. But suffice it to note that the age range they looked at was 45 to 60. But again, when you look at this particular paper, what stands out is that the prevalence of ED in this population of diabetics is actually almost the same as the global prevalence among the Massachusetts study. But it's good to note also this is a study which was done in 2014. So now, how does erection occur? For an erection to occur, we need to have arousal as step number one. And this arousal is by vision, smell, and taste. And this is carried by, is sent from the brain to the cavernoso nerves in the corpus cavernossus and spongiosus. And it acts on the endothelium to cause a release of nitric oxide, which is released in the corpora. And once nitric oxide is released, it leads to an increase in cyclic GMP by inhibition of phosphodiesterase. So you have an increase in cyclic GMP, so the level of calcium in the corpora drops, and therefore the muscle relaxes, and so with that, blood rushes in to the penis. Whenever I am counseling patients on ED, I usually use the analogy of a football and tell them an erection is basically blood just filling a rigid organ, just like air fills a football. Okay, so for as long as blood doesn't flow there, then you do not get an erection. So diabetes is a major cause, one of the major causes of erectile dysfunction, and indeed we say the presence of diabetes and ED is really the perfect storm. It approximately men with diabetes will get ED they're 3 times more likely to get erectile dysfunction than the other cohorts, and worse still, they develop the erectile dysfunction at least a decade or 1.5 decades earlier. They will have a more severe erectile dysfunction, and they will be, whereas most of them will respond to treatment, but they don't respond as well as those who do not have diabetes. And the way diabetes causes erectile dysfunction is by an endothelial dysfunction. Remember the nitric oxide pathway, which we had talked about earlier. There is reduced nitric oxide production. But beyond that also, because diabetes causes both a neuropathy and a vasculopathy, you'll have a reduced blood supply. Then you have reduced transmission of impulses from the brain to the cavernosal, the corpus cavernosum. Aside from that, diabetes also cause a level of hypogonadism. This study done a few years ago indicates that the incidence of hypogonadism is higher in diabetic persons than in non-diabetic persons. What am I trying to say? I'm basically trying to emphasize that erectile dysfunction is not a stand-alone disease. In persons who are diabetic, the level of glycemic control is inversely proportional to the severity of erectile dysfunction. So that for those people with poor glycemic control, then they have a higher prevalence of erectile dysfunction. I hope I got my English right there. The people with poor glycemic control will have a reduced treatment response finally when they get treatment. It is good to note that erectile dysfunction is a very important cardiovascular warning sign. And when you look at the artery hypothesis, the penile arteries are 1.1 to 2 millimeters in diameter, while the coronary artery is 3 to 4 millimeters in diameter. So when we have lipidemias, hypercholesterolemias, and atheromas, generally you'll have the smaller arteries obstructed before the bigger ones. So in a person with arteriosclerosis, therefore, they will present with ED before finally the coronary artery disease shows up. And this is important clinically in that once you see somebody with erectile dysfunction, then that is a warning sign that there may be coronary artery disease, which is going to show up likely in the next 2 to 5 years. Indeed, it's a marker for myocardial infarctions as well and strokes as well. So it is good to note that erectile dysfunction independently predicts the risks of coronary artery disease, myocardial infarction, and strokes comparable to smoking and family history. We have said that ED can be caused by both psychological issues or can have psychogenic causes, but it is also good to note that ED leads to a lot of psychological impact. Men with ED will generally be in a worse mood than those who do not have ED when you meet in your offices. They're likely to be anxious. They're likely to be depressed. They're going to have relationship distress. A few days ago, I had a young man call me and tell me how stressed he is that his wife is going to run away. Never mind that he has only been married for 3 weeks. So in my mind, I was wondering, how does a 3-week-old marriage fall apart? But his problem was that as soon as he tries to perform, the flag goes down. So there is a cycle of stress and distress in erectile dysfunction. Generally, when one is stressed, there is reduced arousal, and because of reduced arousal, there is impaired erection. And because one cannot perform, then they get frustrated and they worry. And because they are frustrated, then there is an increased level of anxiety. So you have a vicious cycle. And I would like to be very clear and inform the ladies in the audience that your stressed man will never ever rise to the occasion. So we see that men seek care for ED earlier than they do for diabetes and hypertension. And this indeed offers us an opportunity so that the presentation of ED becomes the gateway to screening for diabetes and cardiovascular assessment. And towards the end of the presentation, I would like to be inviting pharmacy practitioners that this is an area where pharmacy practitioners can actually play a role in the referral process and the screening of persons with diabetes and ED. Typically, in our Kenyan institution and indeed around the world, we evaluate a patient with ED by history, look at his medical history, and we are looking for those organic causes of ED, check for the drugs he's using, his psychological status and relationship status. But beyond that, for proper quantification, we administer a validated questionnaire, which is the IIEF score. When looking at a number of these IIEF scores, it is interesting. Either in my practice, I usually ask the patient to fill it themselves so that they don't give me the doctor's perspective, but their own perspective. It is interesting that what people feel. Sometimes they will verbally tell you they have done better after medication, but when you look at their validated questionnaire, it is worse than at the beginning. So again, these validated questionnaires have to be interpreted accordingly. In the physical exam, we are interested what the genitalia look like. We are interested in a person's cardiovascular status, and then, of course, the neurological status, looking for any neurological causes. Hemoglobin, in terms of lab evaluation, we generally would like to do an hemoglobin A1C, blood sugar, lipid panel, and a morning testosterone. It is good to note that a blood sugar is something that can easily be done in pharmacy practices, in community practices around. And then part of the advanced test is penile Doppler studies that are now being done more and more in our country today. This is just an example of our IIEF score, which we administer to patients, and it looks at both erectile function and orgasmic function. And then the sexual desire would usually go down in persons who are hypogonadic. And then, of course, when you're looking at the psychological component, you're checking of how satisfied somebody is with their sexual function. The treatment of erectile dysfunction is a multidisciplinary team. I have deliberately left out the pharmacy practitioner here from this particular slide because we are going to look at it later. We'll have the urologist, we'll have the endocrinologist evaluating, and the cardiologist evaluating for various diseases, primary care physicians in areas where we have them, and very important, the mental health professional. But in all this, you must have a spouse. For as long as the spouse is not involved in the treatment of erectile dysfunction, then there is nothing you are doing. Sometimes you may have a spouse who is very happy that the man cannot rise up to the occasion. So you have no business treating the ED, because what does the man do with the erection thereafter? Yet at the same time, you can have a spouse who is demanding, and yet the man has serious comorbidities like the one-term, two-term. So you see, therefore, the management, therefore, has to integrate all these persons, and at the end of the day, you'll see the pharmacy practitioner. Of course, the first line of management of ED is lifestyle modification. We are slowly creeping to what we have in the West. I can see the number of KFCs has increased. There has been this joke about a KFC in Kakamega. I have seen people here indicating they are from Kakamega County. I don't know whether they would choose to eat a KFC chicken as opposed to the true Kakamega chicken. So in lifestyle modification, we want people to lose weight. We want people to exercise more. We want people to stop smoking. We want people to reduce the amount of alcohol they are consuming. And generally, we want people to improve how they sleep, because this allows rejuvenation. But aside from that, when we are looking at this lifestyle modification, we also want people to have realistic expectations. Because if you looked at Mudu Strong said he has ED, yet he's having sex 2 times a day. For most of us who have been more than 5 years in a pharmacy practice, I highly doubt you'll have the energy to do it more than 2 times a day, maybe. I'm sorry, I'm not reporting myself. But you will find that because of your schedule, your age, you're unlikely to do it as frequently as maybe your partner may demand. So one has to be able to counsel people accordingly. Outside lifestyle modification, the agents we have in our country, the common agents we are having in our country for the treatment of erectile dysfunction is actually sildenafil and tadalafil. Both of them can be available as an on-demand dosing. However, the low-dose tadalafil can be available as for daily use. Of course, the low-dose tadalafil has been generally developed for the management of BPE. However, we note that the clients we deal with, especially the older ones, are actually more comfortable taking the daily alternate day dose of low-dose tadalafil as opposed to an on-demand dose of tadalafil 10 to 20, or indeed sildenafil 50 to 100. And you'll be surprised, the other day I got somebody who was using 600 milligrams of sildenafil. Generally, these medications have improved the landscape of management of ED in our environment, both in people who have diabetes, hypogonadism, and those who do not have any of those conditions. It has also been shown that the use of tadalafil and avanafil help in the management of diabetics, in that they generally decrease the hemoglobin A1C. It is not uncommon that the patients we have may not respond well to the PDE5 inhibitors that we give them. And unfortunately for many, after several months of treatment with a PDE5 inhibitor and they do no response, then somebody says, hey, wait a minute, did I examine this man's testicles? How is this man's testosterone level? And this comes as an afterthought. Generally, the recommendation is that we must examine the person's testicles, and whereas a good-sized testicle is a surrogate marker for function, it is good to note that testicular size can be adequate, however, function is low. So we generally need to be able to be evaluating our patients for hypogonadism as part of their profile for ED evaluation. And it has been shown that in diabetics, for example, when hypogonadism is treated there is improved response to the treatment of diabetes. The person also get a little bit more active, and indeed you have an improvement in the lipid profile and the cardiovascular profiles of these particular individuals. Aside from, and the guys who asked me to make this talk have testosterone, which they sell, and I'm sure Simon is going to talk about it. We also do have injectable medications which are available in our country, alprostadil being one of them. These are given intracavernosally or indeed intraurethral. I'm not sure that we have a intraurethral formulation in our country today. The other injections that we have are the bimix and trimix, and I believe Simon is going to talk a little bit about that. There are vacuum devices which are available for use in the management of ED. However, the trouble with the vacuum devices is that when you look at the penile hardness score, they don't achieve a very good penile hardness score. So it is not very popular with the patients we treat. When ED is refractory to the PDE5 inhibitors and the injectable formulations that we have, the next thing we go to is a penile prosthesis. It is good to note that this is currently available in our country, and that bottom left slide I've put there is actually one that was performed, I think, 4 days ago in our country. Access to penile prosthesis is actually limited by cost because the inflatable prosthesis, the prosthesis alone is something just around about 1 million Kenya shillings. When you ask around, do I use 1 million shillings to get my penis erect, or should I use it to build the next floor of my fratty? That's a question which is left to you. It depends on how you value your erection. For those who have had penile prosthesis, their satisfaction is around 90%, and it is said that their partners are also very satisfied with it. In countries that do not have very high disposable income, one can go for a malleable penile implant, which it's almost like a plasticine. Straighten it or fold it. So when you want to have the erection, you just straighten it. And then when you feel you are done, you just fold it. So it offers relief to these particular individuals. Within our country, there are other treatments that are being offered in one place or another. Low intensity extracorporeal shockwave therapy. This is touted to cause neovascularization and has been thought to improve ED in refractory patients in at least 30 to 60% of them. It is available in our country, and there are people who have been going through it. There are also people who are trying to inject platelet-rich plasma and indeed doing something called intracavernosal stem therapy. For our purposes, it's good to note that these are experimental treatments, and one of the major side effects being that we get fibrosis of the corpus cavernossus, and therefore actually make the ED worse and cause other problems. What are we then want to ask ourselves today? How does pharmacy practice fit in the treatment of erectile dysfunction? And this is a question where I'd be very happy that you help me answer. But what are my thoughts? When we look at the regulatory challenges pharmacy practice in East Africa, we are finding that there is a frequent dispensing of PD5 inhibitors without prescription. In fact, it is said that the consumption of PD5 inhibitors increases on Thursdays and peaks on Friday and Saturday before finally going down on Sunday and Monday. But beware that ED is not a standalone disease. So whereas we keep giving these medications, we should be aware that, hey, maybe we should be sending these fellows to have something else evaluated. In our country today, we have very many types of PD5 inhibitors. I can't remember each and every one of them. And at times you want to ask, are these molecules genuine? So there is the issue of falsified molecules, and then also, of course, we have come across these power UGs, power teas, power coffees. You'll find that some of these have some medicaments added into them, and maybe in some scenarios, PD5 inhibitors. When we look at our pharmacy care models, maybe it's time we start seeing, I've seen it in some of our community pharmacies where at least there is a weight check. I have seen blood pressure checks and blood glucose checks. Maybe we need to change our pharmacy care model and make sure that all community pharmacies have these machines so that you can have a quick cardiovascular trial. And then beyond that, we may need to ask our community pharmacies to develop an interprofessional referral pathway so that once you do a diabetes or cardiovascular screen in somebody who walks into the pharmacy, then at least you know somebody to call and say, hey, there's a guy here with a blood sugar of 30, is looking for an erection, but I think he needs to have a consultation with you. So we need to have that a formal way in which we can have that interprofessional referral pathway. And when we look at safety and drug interactions, we know, for example, that PD5s are absolutely contraindicated in patients on nitrates. Who is in a better position to know that a patient is on nitrates as opposed to the pharmacist? Because you are the one who are dispensing these medications, and in the know your customer principle, you probably know what medications they are on. And you should also be able to to advise these patients who are on these medications that, look, I can see you have your prescription for PD5 inhibitors, but I also know that you are on nitrates. So you have to have a washout window. And a typical washout window is 24 to 48 hours. And this is advice that we'll have to, we are in a position to give the patient. And then it's not uncommon that the patients we are treating, if you looked at Mr. One Tutam, is on alpha blockers also. So of course, this use of PD5 inhibitors and alpha blockers would make or worsen orthostatic hypertension. Interestingly, now we have fixed drug combinations of alpha blockers and PD5 inhibitors, and it is said that it doesn't make uh, significant orthostatic hypertension. And then, of course, we know drug interactions with various drugs, and PD5 inhibitors have been found or known to interact with some of these medications, and you're in a better position to advise that. So, in summary, therefore, I hope I've not taken too long, Silvanos. ED is common, but underdiagnosed. There are organic causes of ED, diabetes and cardiovascular disease being the major causes, especially in persons over 40 years of age. And pharmacy practitioners are in a position to perform a screening, especially of diabetes and a basic cardiovascular screen, and refer these patients for appropriate evaluation. And once you send them for appropriate evaluation, it is important that we actually do that. So, treating ED is not just about allowing a man to have sex. It's about evaluating and looking after his vascular health, evaluating and looking after his mental health, keeping his relationship intact, identifying early cases of diabetes mellitus and referring them appropriately for treatment, and generally giving a couple a better quality of life. I would like to end by saying an erection may be the symptom that saves a life. Thank you very much. I have very many references and I appreciate all of them. Thank you.
Yeah, thank you. Thank you so much, Daktari. I think that was a very well delivered presentation. And I can, of course, see the reactions on the chat. A lot of participants are also engaging, which means you've hit the nail on the head. I want to welcome Maritim briefly, and then we switch to respond to some concerns that have been raised. If that is in order, if you can hear me, the floor is yours.
All right. Thank you, Dr. Silvanus. Thank you so much also, Dr. Icole, for that fantastic and insightful presentation. We've certainly learned a great deal from that session. I will also want to extend my sincere appreciation to PSK for this platform to engage on a very important topic in regards to the management of erectile dysfunction. So if you can see my screen. Dr. Silvanus, can you see my screen?
We can. Yes. Proceed.
All right, okay. So, okay.
Yeah, you can put it in presentation mode. And then
is it?
Now it is.
Yeah, okay. So, ladies and gentlemen, my name is Micah Maritim. I'm the Key Accounts Manager at CC Pharmaceuticals Limited. It is my great pleasure and honor to briefly take you through the therapeutic options available for the management of erectile dysfunction and to highlight how these options can support effective patient-centered care. So as you know, erectile dysfunction is a multifaceted condition that intersects between sexual health, mental well-being, cardiovascular risk, and also the quality of life. So in ED treatment, we as CC Pharmaceuticals offers Talgentis 5, which is tadalafil 5 milligrams administered once daily. Talgentis 5 restores confidence, intimacy, and overall quality of life. And we say, life is full of life. So importantly, as Dr. Icole has alluded to, erectile dysfunction and cardiovascular disease are common and closely interconnected. Erectile dysfunction can serve as an early warning sign of underlying cardiovascular disease. And we must remember that ED is not a problem affecting men only. The consequences extend to their partners, reducing the quality of life. Erectile dysfunction and cardiovascular diseases have similar risk factors which revolve around endothelial dysfunction. Therefore, discussing ED with your patients, just like discussing cardiovascular safety, is very critical because successful management of erectile dysfunction may improve treatment outcomes of either diabetes mellitus or hypertension. Turning to the clinical evidence, a randomized double-blind placebo-controlled trial demonstrated that tadalafil 5 mg once daily significantly improved the International Index of Erectile Function score compared to placebo in the both mild, moderate, and severe ED. So importantly, the benefits were sustained through the long-term follow-up, demonstrating that long-term low dose of Talgentis 5 OD is one of the first-line treatment for repairing damaged epithelium and promoting long-term improvement of erectile dysfunction. So aside from demonstrating the efficacy, clinicians often ask whether the daily therapy is better than the on-demand treatment and vice versa. According to a systematic review and meta-analysis of randomized trials, which involve measuring the IIEF, which is the International Index of Erectile Function, the sexual encounter profile number 2, which measures how hard the erection is for successful vaginal penetration, sexual encounter profile 3, which measures the maintenance and duration of an erection. They compared the once daily tadalafil with patients on PRN therapy. The results was that 72% of patients preferred Targentis 5 once daily compared to PRN. And a large number of these spontaneity compared to PRN. 30% attributed to the efficacy, while 11% fewer side effects. So Talgentis 5 mg is better alternative to an on-demand PDE5 inhibitors. Beyond erectile performance, ED is frequently associated with another condition which is often undiagnosed, that is depression. According to meta-analysis of observational studies, erectile dysfunction and depression share a bidirectional relationship. Men with erectile dysfunction are almost 3 times more likely to develop depression, while depression itself increases the risk of ED. Anxiety is also an important contributor, and many antidepressants can further impair sexual function. Therefore, patients presenting with ED should be screened for depression, and those presenting with depression should be screened for erectile dysfunction. And as you can see from the clinical data, patients with both ED and depression were treated with tadalafil 5 milligrams. And on third hospital visit, there was a reduction in Zoom self-rating depression scale and improvement in IIEF score. Therefore, Talgentis 5 OD is useful in treatment of patients with erectile dysfunction and also major depressive disorder. Now, ladies and gentlemen, cardiovascular safety remains one of the most important prescription or prescribing consideration. According to pooled safety analysis involving multiple phase 3 studies, tadalafil showed no clinically significant effect on blood pressure compared to placebo. It was measured after 12 hours of administration, measuring both the systolic and diastolic blood pressure. And you can see they used both 10 milligrams and 20 milligrams of tadalafil. So Talgentis does not affect the blood pressure. Talgentis is also safe to use in hypertension and other comorbid situations. If the patient is taking antihypertensive drugs, either one class, two classes, three or more classes of antihypertensives, they can use Talgentis 5 alongside the products. Also, there was a comparative study comparing the rate of myocardial infarction per 100 patient years across the tadalafil studies and placebo. And the results is that the rate of myocardial infarction in tadalafil was low, meaning Talgentis 5 is not cardiotoxic. So when it comes to tolerability, beyond cardiovascular safety, according to an integrated pooled safety analysis involving more than 3,000 patients, tadalafil demonstrated a predictable and well-characterized safety profile. The most common adverse events were headache, dyspepsia, and back pain, which were generally mild. Importantly, discontinuation rates and serious adverse events rates remained low, even among the older patients. However, suffice to say that there are some contraindication on the use of PDE5 inhibitors. That is concurrent use of organic nitrates and nitric oxide donors, men with cardiac diseases for whom sexual activity is inadvised, recent myocardial infarction within the last 6 months, hypotension, that is 90/50, unstable angina, heart failure, and controlled arrhythmias or hypertension. Having established the efficacy and safety of Talgentis 5, let us look at another important patient population, which is benign prostatic hyperplasia, stroke lower urinary tract symptoms. Erectile dysfunction and BPH LUTs frequently coexist. 1 in 3 men over 50 years of age experience both conditions simultaneously. According to epidemiological and mechanistic evidence, both diseases share the same vascular and nitric oxide pathway, as you can see, making them closely interconnected rather than separate disorders. And the existing treatment for BPH stroke LUTs may cause unwanted sexual adverse events. So in a nutshell, the quality of life is worse when both BPH LUTs and ED are comorbid and causes sexual dissatisfaction. So according to mechanism of action, the treatment of BPH LUTs with Talgentis 5, in a summary, there's increase in the smooth muscle relaxation, testosterone level increases, the nitric oxide bioavailability increases also, and also the concentration of endothelial progenitor cells. And also there is reduced insulin resistance. So Talgentis 5 is highly effective in treatment of BPH LUTs with or without ED. So having reviewed the evidence, let us conclude with the appropriate Talgentis options for each patient. We have both Talgentis 5, Talgentis 20, and Talgentis Plus in our portfolio, whereby Talgentis 5 milligrams is highly effective in ED of all etiologies. It improved the vascular function, and as we've seen, it's superior and preferred to on-demand treatment. Talgentis 5 also is used in BPH or LUTs. It's highly effective as a monotherapy or in combination with either alpha blockers or 5-alpha reductase inhibitors. Post-prostatectomy, you can use also Talgentis 5. It improves the vascular function and is well tolerated. When it comes to Talgentis 20, on the other hand, it's highly effective in ED of various clinical populations, including hypertension and diabetes mellitus. It's effective up to 36 hours. Patients experience benefit beyond erectile dysfunction. There are many aspects of even premature ejaculation where Talgentis 5 Talgentis 20 can improve. It is preferred by patients over sildenafil or vardenafil. In BPH stroke LUTS, this is a new entry in the market, but most of you have seen it. We have Talgentis Plus, which is a fixed dose combination of tadalafil 5 milligrams and tamsulosin 0.4 in management of BPH LUTS with or without erectile dysfunction. It's superior to treatment or with tamsulosin alone or tadalafil alone. It has positive effect on erectile function. It improves the quality of life, and it's well tolerated. And it's convenient and cost effective compared to when you prescribe the two products separately. Now, there are those colleagues who are hearing of us for the first time, and it's very, very important to tell you who we are. We as CC Pharmaceuticals Limited is an indigenous African firm. We are importers, distributors, and marketers of pharmaceuticals and skincare products. We were founded in 2006, and we aim to provide market leadership for innovative pharmaceutical, diagnostic, and healthcare products through our key pillars, which are regulatory support, sales and marketing, and distribution. Our vision is to be the leading importer, distributor, and marketer of innovative healthcare and skincare products. Now, we have some products apart from Talgentis range, and I can take you through. We have in men's health, we have Dynamo Delay, which is used for the management of premature ejaculation. It's lidocaine spray 13%. We also have Profertil, which is used in the management of male subfertility. And aside from improving all the sperm parameters, it's importantly to know that Profertil it reduces the sperm DNA fragmentation, which is a major cause of recurrent pregnancy loss. In the female or women's health, we have Profertil Female for female infertility. We have Menopal for menopausal symptoms. And we have a very interesting product called Diprilox. It is the female version of Talgentis. It is used to treat the female sexual arousal disorder. When a patient presents the 6 domains, which is the desire, arousal, lubrication, pain during the sexual intercourse, when the patient presents the issue with orgasm and also the overall sexual satisfaction, the Diprilox will serve them well. We also have a lubricating gel called Smooth Gel, which is greaseless, water-soluble, and non-irritating jelly. Now, in the infectious disease portfolio, we have Clofort, which is Cefaclor, second-generation cephalosporin. We have both the adult formulation and the pediatric formulation. Clofort 750 is administered BD, and Clofort 500 administered TID. We also have Clofort 125 milligrams per 5 ml and Clofort 250 per 5 ml. We have Fizolin, which is cefazolin, both 1 gram and a half gram, which is a gold standard recommended by major guidelines in surgical antimicrobial prophylaxis. We have Cifroset, which is Cinacalcet, for the management of secondary hyperparathyroidism in patients with CKD and MBD. We have lead control for the management of kidney stones. We have the 3-range lead control pH balance for calcium oxalate stones. We have lead control pH up for the uric acid stones. And we have lead control pH down for the struvite stones. And lastly, in the diabetes care, we have Hamofine insulin pen needles, which are the microfine pen needles, 33 gauge. It is advanced in the market per 4 mm. So thank you so much, ladies and gentlemen, for listening to me. For more information, you can visit www.ccpharmaceuticals.co.ke. And importantly, Talgentis 5 and Talgentis 20 is available everywhere in the hospitals and in the pharmacies through, within the country. So thank you so much. Back to you.
Yes, thank you. Thank you so much, Micah. And we are pleased, of course, to have you support this webinar. So maybe for the sake of time, I wanted to quickly switch to the Q&A segment, where I know there are a couple of questions that have been raised, and we have now the opportunity to respond. So I also just encourage the participants that if you have questions specifically to CC Pharmaceuticals team, please do not hesitate to share the same so that the team can address them before we close. But even then, I just wanted to circle back to our speaker and give the opportunity for Dr. Ecole to respond to some concerns. And I will start with, of course, one question. And this had been raised on the chat earlier. So maybe, Doc, if you can hear me, I will pose two questions for you to respond to before I proceed to the others. So the first question goes like this. Explain the relationship between scrotal varicocele and erectile dysfunction. And the other question is, what is the role of morning/nocturnal erections in differentiating psychogenic from organic ED? If you may.
Okay, thank you very much. I've actually been looking at those Q&A questions, and I've basically isolated around 7 or 8 questions. And if you allow me to answer them one by one.
Oh yeah, sure, definitely.
I think you may not need to repeat the question, and I will start with the most recent one: varicocele and ED and morning erection. Let's start with morning erection. Morning erection is an indicator of adequate testosterone in the individual. Because a morning erection, when somebody is relaxed, there is this surge in testosterone. So that would basically tell you, or is a surrogate marker for that somebody does not have hypogonadism. So for the man, a morning erection is good. When we look at varicocele, varicocele is a very interesting topic in our space. The reason being that less than 5% of individuals with varicoceles actually present with any type of complaints. And indeed, you'll find that we end up treating even less than 5% of the individuals with varicocele, meaning that so many of us can be walking around with varicocele and do not need any level of intervention. However, science has shown that with vascular congestion in the testis caused by a varicocele, that can lead to testicular hypofunction. So it leads to a situation where you have an element of hypogonadism, okay? Or indeed you get a reduced sensitivity to testosterone. So some authors have claimed that in such patients who are hypogonadic and have varicocele, treatment of varicocele surgically improves their hormonal levels. So the other question that was asked, let me just dispense with the ones on testosterone. There was a question on bodybuilding and ED. Exercise generally improves erectile dysfunction or delays it, and especially exercises around the pelvis. The simple reason being that they improve the blood supply. Bodybuilders is a different category of individuals. The reason being that competitive bodybuilders end up consuming some medicaments to improve their performance. And one of the dangerous ones is anabolic steroids. So, of course, when one consumes anabolic steroids, it is going to inhibit testicular function. So because of that, then you do not have a proper intratesticular testosterone, okay, to help in testicular function, and that will therefore affect spermatogenesis, and it is going to affect libido as well. So otherwise, bodybuilding without the use of anabolic steroids is not a problem. But we have also seen bodybuilders use, I think it's called creatinine. There's one chemical they commonly like using. One of the challenges is that that particular medicaments I've seen for my own in my own practice at least 3 individuals who ended up with an element of acute kidney injury from use of some of these supplements used in improving exercise tolerance and muscle building. One of the earlier questions that was asked is, fine, we have been talking about erectile dysfunction, which is pain is too weak or not too hard. And then now there is one where is too much erection. Somebody asked a question about too much erection, and we need to clarify and know whether it is a persistent erection that is not provoked. Of course, in that scenario, we'll be talking about priapism. And in priapism, this is a patient who needs urgent surgical intervention. The other one, of course, is associated with a hypersexual disorder. In this one, you're looking at the right name being actually a compulsive sexual behavior disorder. And this falls under mental health disorder. So for somebody in this category, we usually would like to involve the mental health specialist in their management. I also saw a question on masturbation and ED. Yes, masturbation is a big problem in a particular segment of society we see. And this masturbation, how it causes ED, is interesting. It's more of a psychogenic form of erectile dysfunction these persons get, and indeed very difficult to treat. Why? In this particular individual cohort, what we have noted is that you have people who are living communally, so you have young boys, many in a house, and for them to masturbate, they have to run into their mother's bedroom. So, of course, once they run into their mother's bedroom, they have to masturbate quickly so that they can achieve an orgasm or an ejaculation. So that brings in an issue of performance anxiety and the level of stimulation that one requires to get an orgasm following masturbation is so intense that is the same intensity is not achieved during a vaginal intercourse. And so because of that, this man therefore finds himself unable to perform out of a performance anxiety as the main cause. It is not very easy to treat, but some people I have handled have had success when I engage a sexual therapist, apart from, of course, using the medication also. Scrotal pain and erectile dysfunction, epididymochitis, no, and does not cause ED unless it is if one has had mumps epididymochitis, which generally knocks out the seminiferous tubules. Because the seminiferous tubules are knocked out, then you don't have the factory that produces testosterone. So of course, one ends up with an ED associated with an endocrine kind of element. I think in a nutshell, somebody also asked about premature ejaculation. Premature ejaculation is mainly psychological in origin, psychogenic in origin, and the company, I think it has been presented here, Dynamo Delay. Apart from Dynamo Delay, we also use SSRIs, which act centrally, and the one recommended for this particular condition is dapoxetine because of its short half-life. And then dapoxetine, of course, is taken as an on-demand dose 2 hours before the act. So I think that generally covers what I thought I saw in the Q&A. And if there is any I have not answered, I would be happy to address it directly. Thank you.
Thank you so much, Dr. Thank you so much. I think you've covered most of the questions that had been raised, and that is representative of the conversation tonight. I see there are good feedback even from the responses, so that means we are doing well. I want to give the floor to my colleagues, Micah and Simon. If there's any question or concern you've noted directed to you that you'd like to address, maybe this is the chance. Otherwise, I think we have done well. We are still within time, maybe 9 minutes to go, but we can still, just wrap up with one last concern. So if you'd like to, maybe under 1 minute, just verbally raise a question, I would encourage you to raise your hand. I'll pick one person to direct the question to Dr. and then afterwards we can go to the closing remarks. Micah or Simon, if there's anything you want to add, especially on the products.
Yeah, thank you, Dr. Manyala. We also, once again, like to extend our appreciation to the association, and we hope to do more of this partnership going forward with other disease areas. There is no question directed to us, meaning everything was very clear. Just to point out is that we, as Dr. has said, we also have end-to-end management of erectile dysfunction. We have through a partnership with our sister company, Novesi. We have both Bimix and Trimix. Yeah, so CC Pharmaceuticals, we maintain high standard and the quality of our products, and we are very innovative. We are either first in class or best in class. So most of our brands are very innovative, and we lead and others follow. So thank you so much, Dr. Manyala, and our colleagues in the Pharmaceutical Society. We urge you to stock our products when you come across. Thank you.
Sawa, karibu sana and shukran. So maybe first, as you can raise your concern, and even as you do that, maybe Micah, you can post your contact information on the chat so that participants who would like to engage with you directly, maybe on where to get your products or how to get your products, they can follow up with you. Festus, I give you the floor. If you can hear me, Festus, you have the mic. Okay, maybe as Festus tries to figure that out, I also just wish to quickly switch to the next part, which is basically us appreciating you all for making time to join us this evening. This session was very engaging. Of course, as a moderator, I've enjoyed the delivery, which has been done in a very fun and with a lot of humor, something that we lack in most of the presentation, and this makes it very memorable. And thank you so much, CC Pharmaceuticals, for supporting this session. Hopefully, we get to have more of these, maybe a series of other topics for the range of products that you have in the market. And of course, just for our membership, we also encourage you to engage with us, engage with our sponsor, and of course, with the end goal of ensuring we provide the highest attainable standards of pharmaceutical care. So thank you so much, everybody. Thank you so much, Dr. Icole, and another round of appreciation to CC Pharmaceuticals, led by the marketing coordinator, Mr. Simon, as well as the key account manager, Mr. Micah. Good evening and good night.
Thank you very much.